What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone, welcome to another episode of the Gestalt Education Show. We're coming to you live from election night, Brett. So we got a live audience again with the interns hanging out here. So these guys have just made themselves way too comfortable in the office, Brett. And so,
laying in the beanbag, this is just unbelievable.
I mean, it's amazing. But that is one of the great things about the intern program at Winchester Spine and Sport. You literally become our family and our best friends. And so we're appreciative of those guys. They worked hard today. But anyway, Brett, so today our main topic is on our clinical audit process. So we've talked a little bit about audits, in a lot of different episodes, but until this point, we really haven't kind of broken it down and gotten specific with it. And so that's kind of our goal today. But before I get into that, we got a couple things as far as topics to go over or some things. So we're headed this weekend to Jupiter for DNSA. We're super excited about that. We got a great crew for a rise. We're kind of maybe battling a little tropical storm, but that's probably nothing. But what we're really, really excited for is at the beginning of the year, we're spending 2 weeks on the road. So the first week we're going to be in Phoenix, Mesa, Arizona, to be specific. For the first course is going to be Shacklock's upper and lower extremity hybrid course, and then we're rolling right into DNS baseball with you, Brett. And then we're going to do the exact same thing in Jupiter the second week in January. So if our travels already didn't get us divorced, this might be the thing that actually does it. So
2-for-1 divorce attorney.
Exactly. Hopefully we got someone. So if you know anybody, let us know. But we're just super excited because number one, Brett, you've got a lot of good contacts in the baseball community, and this is kind of their off season. And so not only are we going to have a lot of baseball people there, but we're also going to be in some awesome places that are going to have some good weather, number one, and then some great facilities. So when we're in Mesa and Phoenix, we're going to be at the Cubs training facility. I mean, if there's any Cubs fans out there, this would be worth the price of admittance alone just to come see their digs and to hang out with those guys. And then when we're in Jupiter, which we're going to be there this weekend, but when we're in Jupiter, we're at a Rise, which is Mickey Masucci and David Donatucci's home course. And I mean, it is
awesome there.
An insane place. So anyway, if you guys are interested in those, Michael hasn't been traveling a lot in the last 2 years because of COVID, but now we're kind of pulling him out, and we host him here in Troy. Now we're going to have him in Phoenix and Jupiter, and so we're super excited about that. And then baseball is something that we don't necessarily teach a ton, but when we do, we have some good crowds, and this is a course that I know that's basically been your life's work leading up to this point, and it's something that I learn a ton from every time I see you teach it, and not something you see every day.
No, and I mean, it just continues to evolve. I mean, even like this past postseason, just watching things and thinking things differently. I mean, it automatically makes me want to change the curriculum, and I'm pretty proud of it. I think it's a great baseball course. I really do.
It really is. It's based on DNS, obviously, but you get into hitting, you get into pitching, you get into throwing. I mean, all those types of things, and honestly, it's not just for baseball athletes either. I mean, you could take all the principles that you learn in this course and apply it to rotational athletes. Period. Overhead athletes. Period. It's based on baseball, obviously, but you could take those same principles and apply them other places. So that's amazing. Check those out, please. GestaltEdu.com/courses. The other thing, if you've been to the Gestalt website recently, you probably see a little tab up top that's called Partners. we're lucky enough to know some really amazing people that are willing to give our listeners some great discounts. So Core 360 belt is something that we use every day here at Winchester Spine and Sport. It's something we use in all of our DNS courses. If you use the code Gestalt, you get $5 off any belt, which is amazing. The new one we just added was from Dr. Thomas Schouts. We were with him 2 weekends ago for the MPI Gate course. He was on the podcast, obviously, but then he's willing to give our listeners 10% off using the code Gestalt on humanlocomotion.com. So that includes everything from the GoPro to the medial talofibular drift instrument, his BFR strap, his percussion instrument. I mean, all these awesome things. The Toe Pro. I mean, that is so. All these things are just like incredible little gadgets and things that can really take your clinical expertise to the next level. So if you haven't already checked out humanlocomotion.com, use the code Gestalt and gets you 10% off. So cool.
Love it.
Let's get on with it, Brett. So let's talk about, I want to start you off with the clinical audit process. So tell me, number one, I guess, when you are auditing your patients, what are some of the main questions you're trying to answer maybe? And what are some of the things that you're really trying to kind of dive into when you're auditing your patients, maybe within the session? We'll start with that. So you got a new patient today, you go through your whole exam and assessment, you do an intervention. What are some of the things you're coming back to that is going to give you kind of an idea in that first step that you're making a change that you need to be?
Well, I think, as chiropractors, obviously joint play is a big one. So joint play, tension tone, trigger points in the soft tissues, muscle length, also a really good one. Any neurologic findings you might be, dealing with, functional tests would be another good example. Neurologic, orthopedic test. All those things are on the table. I think here, it's kind of what you are into, really. We're kind of snobs on what we think, but it could be whatever it is that you have studied or into. However, I do think, whatever technique system that you're in, you want it to be changing all of these things. Because at the end of the day, if you think about it, what do we want to do with our patients from a musculoskeletal standpoint? We want to improve joint motion. We want to improve soft tissue function. We want to change how the brain's using the muscles. So if we have ways to audit this, then the question becomes, is my technique actually changing these things? And I think how you and I kind of got to our core 4 was because our core 4 were 100% changing that. And we're mixing and matching other systems, of course, but I think whoever in the world is doing the best job of integrating, especially MPI, MDT, neurodynamics, and DNS. In my opinion, they're getting the best results in the world right now. So, and we're adding in dry needling, we're adding in active release, Graston, factor, functional medicine, fascia. Oh, of course, fascia, huge fascial manipulation now, honestly. So, we're adding these things in. We're big, proponents of SFMA and FMS. So all of that has its place in our system. But I do think, whoever is doing the best job right now of knowing when to use these different systems and how to kind of dance in and out of these different systems is by far getting the best results in the world. So I would say that's an important point. The other important point is, if we're here, I spend my life trying to convince people not to, walk into the treatment room and ask them how their symptoms are doing. So if you're not doing that, what are you doing? So you better be an absolute savant at your ability to audit the body and let the body tell the functional story for you. That way you can educate the patient on what it is we are really doing with them, which is actually changing the function. And as it turns out, if we do a great job of changing function, the pain is almost always going to move in a parallel axis together. And when it doesn't do that, then it's going to beg the question, maybe we have a structural problem that, might require an orthopedic intervention, maybe a surgery, something like that, or injection. Or we're dealing with somebody who's potentially in the chronic pain hospital. So if you didn't know that already, but you're changing all your audits, but your patient is continuing to come in and tell you they're the same, then you know that you're potentially dealing with, chronic pain. And as it turns out, there's a lot more patients in that chronic pain hospital than we ever imagined. So I think that's why it is so critical. And I would just add one more point. I've been doing this for 20 years. the one thing that keeps me from burning out is because every case is a puzzle, and the pieces of the puzzle are essentially everything that I just talked about. So, when you're dealing with difficult personalities, or maybe you're dealing with complex cases, it can really, really start to grind on you and beat you down a little bit. But if you can just kind of stay focused on what it is you're trying to do, obviously to get the patient better, but then selfishly also as a clinician to get you better. And that's like where I think you're going to find like the best clinicians in the world, they have this like sneaky competitiveness about them that it's almost like a competition even within the patient's own body to see, like, just as an example, like if I can, maybe, adjust their subtalar joint or their midfoot and how that makes other changes throughout the body, or if I turn muscles on in the foot, how that changes the range of motion of the hip. And when you start to understand these interrelationships and appreciate them, it really makes for a lot more fun in your day. So whenever, people are getting burned out and things like that, typically the first thing I say to them is, are you going through this auditing process? Because if you are, I think it allows you to kind of get through those difficult long days when you have 3 people that are telling you they're no better, and just those difficult cases. I just think that you and I, we have an ability, everybody does, to completely change the function of someone's body, and because of that, it's we have just the best job in the world because of that, I think.
Right. We started with, we got a couple PowerPoint slides that are kind of guiding us through this whole thing. And so the first one is within session reassessment. You got some names listed out here. So talk us through how you're willing to kind of take some things from these people to add into your within session reassessment.
Yeah. So, the first name on that list is Jeffrey Maitland. Jeffrey Maitland was a physical therapist and, considered to be one of the top like clinicians in the world. And to his credit, he was the first person to really kind of operate within a system of manipulation and soft tissue work and all the other things that we do. So he's had a lot of really good contributions, but anyways, one of them was that when we get done doing our intervention, how important it is to come back and recheck what it is we're doing. Now, what Jeffrey Maitland did is a little bit different than what we do. However, the point is he felt that it was very important. The second name on that list, I don't know if anyone's heard of. His name is Lynn Fay. He
former podcast guest. You should go back and listen to that one.
He instilled to this day at 84 years old. If you hear him talk about, what Motion Palpation Institute as it started and as it continues to move forward, one of the most important things is we palpate our joint play, we do an intervention, and then we come back and we repalpate. Because if we haven't remedied the exact plane of motion or the joint blockage that we want, then that may lead us to doing something more with the patient. But if you don't palpate again, then you don't know that. And then I also think that, joint play in itself is literally a serial event that you're working on with the patients. Nate, you and I today, we had with one of our patients, like I educated the patient on, today the cavitation was different, the joint play is different, because as we continue to, plug in our treatment, we are improving joint play. What that means is if I blow up your low back today in a good way, that doesn't mean when I see them the next time that everything's perfect, but we're slowly but surely starting to restore joint play. And I think Lynn Fay has been so good at educating us on that this is a process that takes time. Mm-hmm. So he would say the SAID principle, specific adaptation to an imposed demand, which I 100% agree with. So the hard part for those of us in this evidence-based circle is you got to see your patients a little bit to make that change. But I think like a really good audit for the patient is to educate them and kind of show them how we're starting to restore motion. And if you're 80 years old, you've never been to a chiropractor, and you got a big old stiff thoracic spine, we may not get release of the joint or cavitation for 2 to 3 weeks. But then at that 3-week period, then we're slowly but surely starting to release the joints and get cavitations. But I think it's easy to just discount to think, oh man, this is so stiff, I'm never going to be able to move that. As far as joints go, a little bit goes a long way. So
that's exactly right. And then at the bottom of your list here, there's a ton of good names: Syriax, Coltonborn, Manel, Mulligan, Butler, McKenzie.
I love how you did that. You didn't want me to go through all of them.
No. But I think it joins to a good point, because McKenzie, people may have taken a McKenzie course or several, and they'll say, well, they're just talking about the symptoms. They're looking for centralization. But in all honesty, MDT is based on movement principles, meaning you may not be changing their symptoms right now, but you may be changing their range of motion or changing their ability to side glide to the right or to the left, and that may give you a clue that, hey, I need to keep going.
Right.
So it's not always symptomatology, which is MDT kind of gets a bad rap for that.
Well, I mean, I think we get to our kind of the devil's advocate of everything I just said, because in McKinsey, it is almost obnoxiously a constant asking of the patient subjectively of how they're doing. So how do we reconcile that? And I think the answer is, I mean, obviously if we're dealing with radicular symptoms and things like that, we are wanting to know whether or not we're achieving centralization or localization in the extremity joints. So we're asking the right questions in that case, but then usually, once that patient's centralized and abolished, we're then moving them into these other, technique systems that we're doing. And so I think that's kind of how you can reconcile that thought in your brain. But also, like, if you, let's just say you're a hardcore McKinzoid, which we kind of are closet hardcore McKinzoids, but like, what if your patient didn't have any symptoms today? Could you still use a McKinsey protocol in that patient who doesn't have symptoms? And I think we would agree 100% that you could, because the definition of derangement is movement obstruction.
That's right.
So maybe they don't have symptoms, but you palpate their CT junction and they have a big old joint blockage there. So your audit now changes, because it's not about symptoms. Now it's about improvement of joint mobility. That's right. It doesn't always have to be pain, although McKinsey kind of gets a bad rap for, always subjectively asking how the patient's pain is.
That's exactly right. Yeah, we had a patient this week. I can't remember who was working with me, one of these guys, but they had a lateral obstruction. So they were obstructed going side gliding to the right. It would have been an easy thing for me to just go right into side glides and get rid of that obstruction. Instead, we did extension in lines. We did a bunch of press ups and improved that side glide. So meaning, like, that was a great audit for me, because we changed that range of motion. We changed that audit with something that was not just that range of motion. So using those little things and those little cues are a good way to, especially as a young clinician or someone that's, trying to gain this knowledge, those are the little things in your day that give you confidence to keep going and keep going and keep going. And from there, I mean, you can get some good confidence to push on to your patients. So. And
what's fascinating, and I think it was 2003 or 2004 when Keating's first paper came out in Australia, they found that if you were able to change range of motion in the patient and you were able to decrease pain on the VAS scale, so if you did that at the end of the visit, that was a predictor of how that patient was going to come back to you the next time you saw them. So if you were able to accomplish those two things, and it was you were basically predicting the future to know they were going to come back and tell you that they were doing better. And then also, if you were unable to do that or accomplish that, then that also was a predictor to show how that patient was coming back. So in saying all that, though, I actually do not think that the most important audit is after the session. I think the most important audit would be the next time that you see them, because that basically tells you over that 48-hour period or however long it's been, were they able to actually maintain their changes? And then what that tells you as a clinician is that tells you whether or not your portal of entry was correct with the patient, meaning if, let's say that you're doing a lot of your work away from the site of complaint, so the patient comes back to you and you're re-auditing the body and you see that they were able to maintain those changes, that tells you your intervention was probably the right idea, and whatever you chose for a home exercise was also a good idea. So, and that's kind of the game that I'm talking about that we all want to be playing, is that we have the body, basically, as the famous book says, the body keeps the score. Mm-hmm. So no matter what they tell you, because as we've all learned, a patient might, they might have got an argument with the spouse, they might be hungover, they might hate their job. All of those is going to play into how they're going to manifest and tell you how their pain is that day. Mm-hmm. So we need to, take that into consideration, but we also want to go to their body to see if we're actually helping them. And then in saying that, though, I mean, oftentimes, this literally happens multiple times in my day where the patient is telling me they're close to 100% better. Like maybe it's the second visit, let's say, and I'm going back to the audits and I'm like, well, you are the same. Like nothing has freaking changed. Right. So either my power of suggestion is that good or there's some other mechanism at play. But I think that that is a really, really important case to talk about, because if you cut that patient loose right there, they are about to relapse, right? And I always say that whether or not they come back and see you probably is dependent on your personality or your charm or something
Good
else.
looks. That's mine.
Yeah, good looks. Yeah. So, anyways, that's where you have to buy into this system that we're talking about, you know? And again, it doesn't have to be exactly the audits that we're talking about, but it'll probably be something, you know, similar. And that is basically giving you the roadmap for every single one of your patients. And, you know, we're talking about those patients that fall in that black hole where you don't have a chiropractic miracle in 48 hours. You know they're not going into surgery. So what do we do with those patients? So what you do is you continue to change function for them. Be there for the success story. You know, I feel like the evidence-based group is so quick to cut that patient loose at that point and say, we're not helping you. However, you know they're not going to surgery. Right. That patient's about to cheat on you. Yeah, they're about to go somewhere else, and it should be you because you are the best in the world at changing function, you know. So I think that's a really, really important point, to give yourself enough time to be successful with that patient. And if you're not bought into the functional model, you got to get bought into it. You got to believe it yourself, and then you can exude it. You can't sell something that you don't believe in yourself.
That's exactly right. That's a hard lesson that I learned early on, is because you and I shared a wall my first couple of years of practice. And so I don't know how many times I'd come in and be like, oh, I need a surgeon for this, or I need a surgeon for that. And Brett would say, just calm down. You're going to be the hero. You just need more time. You know, you just need to stick around, man. You're doing great. Just stick around. You're doing fine. Just stay there. And sure enough, you just keep working on the little things. You keep checking on your audits. You keep working on those things. And the next thing you know, they're doing a lot better.
Because honestly, too, like to that point, if you're not changing their pain, you better damn well be selling them on changing their function, or they're going to be out. So maybe they continue subjectively to tell you that they're no better, but you're able to report back, actually, this is doing quite a bit better here, you know, and I think we're fine. And then I was actually having a conversation with the interns earlier. What the patient wants to hear is they want to hear that you have all their next steps. So let's just say this were to continue to spiral out of control. One thing that you'll hear me say throughout my day, like especially with a new patient, is, you know, if this doesn't go the way that we think that it is, I have your next steps. We got the back line for epidurals. We have the surgeons, all the best surgeons in St. Louis. So that is what the patient's wanting to hear, because what no one's wanting to hear that's listening to this is the chiropractor, the physical therapist, or the ATC. We're the low man on the totem pole, right? So the patient doesn't always think that we are going to have that next connection for them, but they love to hear the fact that, you know, if the thing's not going well, that we're going to be able to get them connected to the next step. And I would just say the best healers in the world, they always offer reassurance. So some of these great evidence-based chiropractors, which is us, you know, sometimes they're top 100 chiropractors in the world, but they don't get miracle after miracle simply because they're always questioning themselves. Therefore, they're not able to offer that difficult MS patient reassurance, or whatever the example might be. So what I would recommend is, like, you want to be an amazing chiropractor, of course, but we also want to have that ability to offer reassurance and also be a great healer. Right. And that kind of gets us to the explanation of why there's some jackwagon in your town who's a shitty chiropractor or physical therapist who has a huge old practice. I can guarantee you they are great at certainty, education, you know, they have something, empathy, they're doing something to will their results better. So we might as well just encompass it all, right?
That's right.
Yeah.
That's right. That's like people that boohoo on the placebo effect and, you know, things like that. But at the end of the day, I mean, everything includes those types of things. You might
the most powerful drug of all time.
Exactly.
The placebo.
Exactly. So utilize it for your own good. So, Brett, what if we just ranked you personally, your audits? Like where do you classify them in yourself? Like, what are the things that you you hold to a higher standard in-person audits, or maybe visit to visit? Yeah,
so like in a perfect world where I'm not having there's always outlier cases where you talk about pain earlier than you want to, etc. But like in a perfect world, I like to walk into a treatment room and I like to check the mechanics of the joint. When I say the mechanics is how's the joint moving, how are the soft tissues behaving around that area. Maybe we're coming back to a neurologic test, a deep tendon reflex. Maybe we're coming back to a functional test. So that's the first thing. And again, the liberating moment for all of us is when the patient realizes that you're not so concerned about their pain, that you're there to change that. And that in itself will be so liberating for you and will literally free you if you're able to do that. So that's the first thing I want to do. So I'm like from the, previous visits, I kind of know what I need to come back to see if, that key link is better. The next thing would be function. And by that, I mean, we've hopefully picked out like their, activity intolerances or their mechanical sensitivities that, the first day they were like, well, I'm unable to jog right now. I'm unable to sleep. I'm unable to chew because of my TMD dysfunction, whatever it might be. And then that would be another next great set of questions, which would be, when you first came to me, you said that you were unable to walk a mile because of your spinal stenosis. I'm sure you're still having discomfort with walking, but have you been able to improve your capacity of your walking? By the way, yes, actually, I can now walk 2 miles. So you can actually start to make them verbalize that they're actually better without them wanting to tell you better or without them realizing they're better.
Right.
Like I had a couple cases today where they were actually better subjectively from their pain. They just in their mind hadn't really put it together that they're actually better. So, and that's actually important for them to kind of realize that we know that you're still hurting. I'm not saying that, but we want to know, are we on the right track? Because the reality of it is a lot of our cases, over the period that we see them, we want to see a positive slope of improvement, but we have good and bad days. I mean, so you got these little dips and valleys along the way, but if we look at the case trajectory, it should be a positive slope of improvement. It shouldn't just flatline and look like this with us, continuing to do the same thing. And then the third and final thing would be if you're wanting to ask this question would be like, how, okay, so how are your symptoms have been? The reason I say that is you usually never have to do that because at some point in that interaction, they are dying to tell you how they're doing, good and bad, right?
So right.
Yeah.
I think a good little maybe game you can play, if you will, is sneaking in those times where they say that they're not better, but then later on in the visit they're saying that they're better. And so I think that's something you do really well too. Is like, oh well, yeah, I noticed that you said that you weren't able to walk that far, but then have you actually been able to? Or like approaching those kind of awkward conversations where you kind of interject in the right time. And I think that's something that you're like sneaky good at. You maybe don't realize it. So how do you approach those kind of awkward conversations about like, hey, no, you're actually doing well? Well,
I think too, you got to watch because you definitely don't want to undermine what they're saying. And the reason we've kind of gotten away from outcome measurements or surveys is because back in the day I was so bought into it. So the patient would fill out an oswestry and then the next time I saw them, their oswestry would be 2 points better, let's just say. So then I'd come back and be like, well, yeah, on your oswestry here you actually it looks like they're like, I don't remember filling out the first time. I'm just filling out to fill it out. So you're like, okay, so that doesn't matter. But no one wants to also feel like you're kind of mind deafing them, twisting what they're saying. So I think you just got to do it in your own special way to kind of show that there is some improvement. If there's not, there's not. And, then we're back kind of on the functional thing.
Yeah. And I think just being honest with your patients too, I think that's something that I've learned from you over the last couple of years too, is just being honest. When things are not going well, be honest about it.
Yeah.
Just say it.
Don't hide ever from anything.
Right.
Just like in life, don't lie. I mean, just don't be a dick. Don't lie. It's just, exactly. There's some simple rules of just being a good human. I mean, it's no different as a clinician,
It's a joke around this office, but every time you walk in, let me guess, you're no better. Yeah, I expected that. I thought so. Yeah. But I think just being upfront with them and being like, no, I know where you're coming from. I know that you're no better because these are the things that are not changing. So I'm thinking about your next steps and I know this is probably where this case is going. But it's not to worry. We have the next steps. We know what's probably going to happen next. But I got you. I think that's the thing. You're still holding their hand even though it's maybe not going how you want it to.
Or at the end of the visit, I say there's two components to you getting better. There is what you're telling me. So, are you better or not subjectively? And then there's everything that, these audits that we're talking about. So your audits today, I would say they're 50% better, although you're telling me you're no better. So to me, that's a good sign. Yeah. And what is so crazy about human beings, that statement alone will almost always instigate them saying, actually, I do think I'm a little bit better. So again, it is human nature to bitch. Just remember that, and I mean, especially if you're a middle-aged man who, the only reason you're here is because your wife wants you to be here. You have to justify why you're here. I mean, how many times does that profile patient tell you, I have a really high pain tolerance? And you're like, oh my God, are you serious, bud? Yeah.
They're freaking crying.
You pull out an acupuncture needles and they literally start whimpering. You take a female, you could put that thing through her eyeball and she wouldn't say a word, So, I mean, it's like the irony of that is insane. But so it's like sometimes people are having to justify why they're, receiving treatment and things like that. So again, we're back to what they're saying subjectively. I'm not saying it doesn't matter, because it does. But we want to be really good at auditing the body, And then again, too, that is also going to expose whether or not you're dealing with a chronic pain patient. And obviously we've learned through World of Hurt and Annie O'Connor and others, Laura Mar Mosley, that those people that are in the chronic pain hospital, they get treated a little bit differently. We say different things to them. We're working on changing their diets. We're trying to get them moving. We are, giving them that boy speeches. We're doing all these things that should be kind of just baked in the cake. Because I think the great clinicians, they don't walk in and say, oh, this is a chronic pain patient. This is a purely peripheral musculoskeletal case. The great ones they know what they need to educate that particular patient on. They know that they need to change their diet eventually. They know all these little things, and they they're kind of waiting in the weeds, waiting for the right time to strike. And when the time's right, then they nail them.
Exactly. Yeah. It's a game we play with the interns too, is you look at the intake paperwork and okay, what do you think? Let's make some assumptions here. And as the clinician, you can't necessarily make assumptions before you walk into the room, but for the interns, it's a good kind of a thing to get them repetitions on. Okay, this is what I think may be happening here. These are the things I may need to look at. And so I think that's a good way to kind of approach it. It's you have low back pain, but you also have on the review of systems, you've got 30 things marked on their digestive problems, anxiety, depression, et cetera, et cetera. They're on multiple medications and stuff. And so then you can kind of prep yourself for that. You already probably know that that's a little bit of chronic pain, or there's some other things that may be going on besides musculoskeletal.
Oh, I think too, in MDT, they basically teach you to look at that pain chart. I mean, you can smell a derangement before you even see it off paperwork, just by how they're drawing their pain, or, the better worse section, or, whatever part of the paperwork that you'd potentially be dealing with. I mean, it's going to tell the story. So
that's exactly right.
Yeah.
What about, Brent? Let's, we've kind of talked about normal everyday patients. How about your athletes? Do you have anything different than you maybe look at for, let's say you got a pitcher that's that you're seeing on their 7-day rest, and they're maybe pitching tomorrow? Is there anything maybe you change, or anything you're looking at differently, or is it still kind of the same exact stuff?
I think too, back to having a little bit of tact, meaning I'm going to walk into somebody tomorrow who is just a very average high school baseball player. So that care does not need to be taken to a Ferrari-like level. I mean, it can be if you feel like it's necessary in the case, and things like that. But I think sometimes that can also be harmful in certain ways. So, but I mean, if you're being paid by a professional team or a college or if someone just privately is wanting their body to perform like a Ferrari, you want to have the skill set to be able to do that. And, the analogy that I always use, and I've kind of partially stolen it from DNS, is, if we have a normal developing baby at 10 months of age, if we spring their joints, if we check for trigger points, if we check their soft tissues, all of that is going to be perfect. So really what we're really trying to do with our patients, if you think about it, we're trying to return them back to that state. Now, that's not realistic, but it gets us to this really crazy philosophical question of, when is your patient actually done? So when you cut your patient loose, whether it's an athlete or a regular patient, are we saying every joint is springing perfectly in all three planes of motion? Are we saying that the soft tissues are a perfect length and tone? There's no trigger points. All deep tendon reflexes, when we tap them, are perfectly 2+. So the answer a lot of times is no, But what I would say is, do you have the tact as a clinician to give Ferrari-like level care when you need it? And then do you know when you're dealing with a Ford Escort, and nothing's wrong with a Ford Escort, it gets you from point A to point B, but you can't treat 35 people a day like Ferraris. You just will not have the mental bandwidth to be able to do that. So you want to be smart enough. And I mean, if you are, you're drinking 12 beers a night, you're depressed, you're smoking 2 packs, you're automatically telling me you don't want to be a Ferrari. So, there's 2 different things you can do at that point. You could, here's my card, when you're ready to get everything straight, come back in and see me. Or, I mean, I think everyone in around here, we're all kind of humanitarians. We're going to meet you where you are, and I'm going to slowly try to chip away at your lifestyle and try to maybe get you to walk a mile a day, maybe clean up your diet a little bit, maybe, I don't know, have better relationships, whatever it might be that they're struggling with. So, so I mean, to answer the question, I think you could treat everyone like a Ferrari, but when you've done it for a while, at the end of the day, like, it's fatiguing. So that would be exhausting.
One, I think something that I've stole from you, I've added into all my presentations I use, is that can you give your best performance on the biggest stage? And I think the thing that separates people that can do that is that they probably have a system in their mind that they're doing. It doesn't matter what's in front of you. You're still probably going through the same kind of checklist.
Oh, absolutely.
And so like that probably separates the greats from maybe the people that get squished under the pressure of, like, you're still kind of going back to those same things. It may be $1 million athlete, but you're still taking care of their soft tissues. You're looking at their range of motions. You're looking at their detendon reflexes. Like, you're not taking shortcuts in those types of things. The treatment may be different, but the audits and the assessments are probably similar.
I think to that's a really good point. I mean, I think like a lot, like I'll get referrals from my friends that are like just difficult cases for them. I know they're great at adjusting. Maybe I know they're great at ART. I would be an absolute fool to walk in that room and duplicate what's already been done. Even, let's just say that maybe I was a little bit better than them. This is hypothetically saying, like, that difference probably wouldn't be enough to like turn a real difficult case. Sure. So, I mean, like, have some brains about yourself when you walk in there to know, like, if A, B, and C has been done already, don't repeat that. Like, do something different and, set yourself up for success. And like we always talk about, never like cut anyone else down.
Exactly. Yeah, exactly. No, I think that's another tenet that I've learned from you is, like, every patient is a new puzzle, which you've said already today, but every patient is also another opportunity. And so the more you check these things, the more you have kind of a routine that you're going through these audits or these little things throughout your day, that even if you're had a rough day, you're at the end of your day, you're trying to get out of there and stuff like that. But if you don't shortcut yourself, you're not going to shortcut your career. So those are the little opportunities to get better and better and better. So.
Yeah, I mean, like we talked before about pattern recognition, Bobby Fischer. I mean, it doesn't matter. Whoever's like really good at like their craft, they are really good at gathering information and then deciding, what their intervention is going to be, and then, acting upon it. And then if they need to call an audible, they're able to do that. And I think that's a really big mistake in chiropractic, where you just keep doing the same thing over and over and over again. And I mean, honestly, that is a problem legally, but it's also a problem as far as like maybe why you're not getting the results that you're wanting to get.
I think it's a great point, maybe a great finishing point, Brett. You've told amazing stories, and maybe you could tell one now of what happens when your audits are staying the same and you're suspecting something more sinister. Like, what do those situations look like, and how can audits lead you down that path? Yeah,
I mean, I've definitely, I guess I've been lucky and unlucky in my career, because I feel like, especially early on, I saw just some insane stuff. And I think like as a human, I'm by nature a little bit of a worrier, so I'm kind of a worst case scenario human being. Like I'm an eternal optimist, but I'm always thinking
Not
like
really.
Let me that's true. With my patients, yeah. I kind of believe that. But I'm always in the back of my mind thinking, am I missing something? And like, do I I've said it before, like clinical intuition is clinical recognition, which basically means if you're paying attention throughout your day, when you feel something that feels a little bit different it should put your antenna up to kind of think, well, maybe this is just an outlier, or maybe this is cancer, maybe this is, I had a breast cancer case I will literally never forget, where it was a male, and stiff thoracic spine, unstable scapula, poor respiratory patterns. There was more to it, but that was the gist of it. Saw him one time, took care of those things somewhat. He gets up, he had his shirt off, and the muscles around his shoulder blade just literally started to just shake. I mean, almost went schizophrenic. So I thought to myself, that is strange. I have never in my life seen that. So he comes back the next day, a couple days later, he's exactly the same, if not worse. And I do the exact same thing. He stands back up and literally watches the same thing happen again. So I was like, you know what? I was like, it's probably nothing, but let's just get a thoracic x-ray just to make sure we're not missing anything. So he had breast cancer, and it metastasized to his thoracic spine. Now, you're not always going to be so lucky to have it. I mean, everyone who's listening to this would have been able to do the same thing. My point is, you're not going to necessarily be Nostradamus and be able to predict everybody's stuff, but you'll probably save a couple people's life a year by paying attention to the stuff. In any catastrophic visceral problem that you could name for me right now, I could show you how it will manifest itself in the musculoskeletal system through tension, tone, trigger points, and joint blockage. So when things continue to come back exactly the same, you have to, in your differential diagnosis, be thinking about the other possibilities. It could be gallbladder. It could be mono. It could be kidney stone. It could be... it could be cancer. It could be all these different things. So at the end of the day, you really want to be sure that you're paying attention. I mean, the thing that always jumps out to me is the case that I hate the most, honestly, is concussions. And the reason is because, the debate that you're always that's gonna run through your head is, should I do a CT or not? And if you don't see it, if you decide not to do the CT, you will not sleep one wink that night. And when you see that patient the next day, you will give them the biggest hugging kiss you've ever seen.
So true.
And I'll never forget, because they were doing X Games, and this is the one that I'll never forget, where this guy, he's on a snowmobile and he under rotates, and he just basically face plants on this ramp. And so then him and his buddies are giving him a high five, and he's just kind of walking down. He's a little bit jacked up, but he's fine. He was dead in 24 hours. So always wrestling in your mind, do I need to get imaging here? Do I not need to get imaging? And I think you go to chiropractic school and you're almost sold this false sense of a lot of things, or you're actually scared to do anything, so it's so two ends of the spectrum. But so we have a difficult job, and if you're doing a good job, what you're going to find, your patients are asking you about everything. That's how they trust your opinion, because they will literally talk to you about anything and everything as far as their healthcare.
Oh man, we could write a book on that alone.
Yeah.
Erectile dysfunction, or constipation, or diarrhea, or your spouse, or whatever. Yeah, too much.
Yeah. Oh man,
too much. Well, I guess my big takeaway, even from listening to you talk today, Brett, is just to continue to work on those little things throughout your day. There's a lot of days, we travel, we come back on a Monday, and it's man, I really don't feel.
I don't have it.
Yeah, I just don't have it. But then it's those little things that you go back and you palpate a couple more things, and you just kind of get in the flow. And I think if you just keep paying attention, it keeps being interesting, it keeps getting you intrigued, and it keeps getting you involved, and so it makes it so fun. I mean, yeah,
the auditing process literally will become a puzzle for you. And what it'll do too is, what makes it even more fun than a puzzle is that, imagine working in a puzzle where you put two pieces together here, and all of a sudden you've fixed something over here in the puzzle. And that's how the human body is. So it is, it makes, and I think we've learned from Dr. Levitt and others that are, and Lynn Fay would be another guy to put in that category, is they almost as they age, they're almost gaining energy in a way, because they're wanting to apply all of this knowledge that they have, and then unfortunately you just kind of run out of years, which is kind of ironic, but anyways, that's how the story goes.
The good thing, Brett, you're in your prime, baby. So
yep, 45, let's go, baby.
We got some crazy crazy travels coming up. So we've got, I won't announce it yet, but just hold on to your pants because we're going to have a crazy travel series that are coming up in the next week. And we're going to interview one of our bucket list people in the next week, which is going to be really exciting.
Yeah, it's going to be awesome. It's going to be insane.
Stay tuned to our Instagram. That's kind of where I'll update you all on our travels. And then again, if you are interested in taking a DNS course or neurodynamics with Shacklock, Stecco, we have March with Stecco, gestaltedu.com/courses, and then please reach out to our sponsors, man. We love these people. These aren't just people that we randomly reach out to and stuff. Like the people that are our sponsors, the people that we're involved with, are the ones that are our best friends, the people we really trust their stuff, literally. And so Thomas Shoud, the Payday Practice. We've got also Core 360 Belt with Aaron McGuire. And so like all those people are people that we're promoting them because we actually like care about them and we know that their stuff is legit. And so use the code Gestalt on everything. I don't know, put it in Amazon, put it in anywhere you can find it. Maybe there'll be some discounts or maybe we'll get a kickback somewhere, but I don't know, whatever. These guys have been buying tables left and right. And so put the code Gestalt and see what happens. Maybe we'll get a 10% discount to them too. So anyway, keep auditing your patients, number one. Number two, visit gestaltedu.com and buy some of our shit. And we appreciate all you guys. So stay tuned for the next stuff coming up, and we'll see you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.